So good afternoon, everybody. Thank you so much for the introduction. My name is Aoife Williamson. I'm a consultant therapy radiographer working in Neuro-Oncology at the Beatson in Glasgow. And today I'm going to talk to you about capturing the impacts of a consultant radiographer and what this means for our brain tumour patients. I have no conflicts of interest. So as we all know, radiotherapy is central to the management of brain tumours. Therapy radiographers, as we are known in the UK, or radiation therapists, as we are known in Europe and in Australia, Canada, and New Zealand, we deliver the radiotherapy for our brain tumour patients. And we are the only healthcare professionals qualified to plan and deliver radiotherapy. Now, for those of you who are not familiar with radiotherapy, the image on the right is an image of a linear accelerator, which is the machine that we deliver our radiotherapy with. And we have really advanced technology in radiotherapy currently, and this allows us to safely deliver precision radiotherapy for our patients. Now, to become a therapeutic radiographer, we have to do a 4 years BSc honours course. This course involves physics, maths, anatomy, physiology, radiobiology, and once we complete that course, we can work as a therapeutic radiographer. Now, for somebody like me who's moved into advanced practice and a consultant practice role, we then have to go on and do a master's in advanced practice in radiation and oncology. And now in my role as a consultant radiographer, my responsibility is to provide a seamless pathway for patients receiving radiotherapy. I need to ensure that I act autonomously, that I'm an expert practitioner in neuro-oncology, and my responsibility is to assess, treat, and follow up patients with brain tumours in my department. So when we talk about advanced practice, we always talk about the 4 pillars of consultant practice. And when I was thinking about putting this presentation together, I was thinking about how do we change this around and how do I actually demonstrate what I do for my patients? So what I decided to do is, as opposed to we talk about domains from clinical practice, I'm going to use these domains to demonstrate patient-centered care. And I'm going to describe 3 of these boxes, so expert clinical practice, professional leadership and management, and research and development. And I'm going to demonstrate how I, as a therapeutic radiographer, enhance patient experience and outcomes. So firstly, expert clinical practice. And hopefully this is going to demonstrate how I enhance patient experience. So back in 2010, I've been doing my role for a long time, our nurse specialist that I work with, Mary McKinnon, and I felt that our patients were attending the radiotherapy planning appointments, and they really didn't have much information about what they were attending for. When the patients meet our clinical oncologists in Glasgow, they meet the patients just after they've been informed of the final pathological diagnosis. And patients at this appointment are very upset, and they're busy trying to process what this means for them when they have a diagnosis of a high-grade brain tumour. And they don't retain any information about the treatment plan. So Mary and I implemented a pre-treatment assessment clinic, and this clinic takes place approximately 2 or 3 days after the patient is seen by the clinical oncologist. And for this appointment, we invite the patient and their family to attend our clinic, where we discuss we undertake a clinical assessment of our patients. We discuss the medicines that the patients are on and make any modifications to medicines. We discuss rationale for radiotherapy. Mary discusses rationale for chemotherapy. I talk about toxicity profile of our treatment, and we also obtain consent for our radiotherapy treatments. And what Mary and I certainly found since we implemented this clinic is that patients now attend for their planning appointments and they understand what's going on. And in turn, that reduces the stress that they are under and the anxiety they face when they enter our department. So this is something, as I said, we've been doing for a while, and we've got really positive patient feedback about how this clinic enhances their patient experience. Another area of expert clinical practice that I'm involved in is our radiographer-led brain metastasis clinic. Now, this clinic was set up a couple of years ago when I became a consultant radiographer. And really, one of the main aims of this clinic is to ensure a fast, efficient referral process for our patients. We like to deliver radiotherapy to brain metastasis when they're small, and speed is of the essence of seeing our patients in the clinic. So within this clinic, my responsibility is to describe the rationale for our stereotactic radiosurgery treatment. I talk about a toxicity profile of our treatment. We ensure that these patient appointments are about an hour in length, and that really gives patients an opportunity to ask questions, to talk about their concerns. And by doing all of this, hopefully we're ensuring shared decision-making for our radiotherapy treatment. And certainly after we implemented this clinic, we undertook a patient experience survey, and we asked the patients lots of questions about how they found the clinic. And I've just given you an idea of some of the questions here. So firstly, we asked, was the proposed treatment clearly explained? And you can see that 90% of our patients agreed that they thought that the treatment was clearly explained to them. Was the information given easy to understand? And 95% of our patients said yes, that it was. I was given time to talk about my concerns. So again, 90% of our patients said that they felt they had appropriate time to voice their concerns about the treatment. And I felt involved in my decision-making about my treatment, and 85% of our patients felt that they did. And again, hopefully this patient experience survey really shows that radiographer-led clinics can be successfully implemented, keeping the patient at the heart of everything that we do and ensuring that we have a positive patient experience. So now I'm going to move on to professional leadership, and a large part of my role is implementing advancements in radiation technology. In the last 10 years, our technology in radiotherapy has come on so much. And this is an example of a project that I did for my master's dissertation. And I actually did this back in 2013. It's something that we presented at ESTRO, which is our European Neuro-Oncology conference, or sorry, European conference, and something that we published on. And basically it's comparing our old radiotherapy technique with a new radiotherapy technique. So again, I know that some of you will not be familiar with these, so I'll talk you through these images very quickly. The area in red here, it refers to the target volume for meningiomas. And a meningioma can be quite difficult to treat because it grows along the meninges of the brain, and we can have very irregular treatment volumes. So with our old technique, we've put on the high dose area here, and you can see that the area in red, the unusual shape, there's a lot of high dose area actually being delivered to the adjacent brain with this 3D conformal radiotherapy technique. And again, when we look at the coronal and the sagittal, you can see that that dose goes out beyond our target volume. But when we implemented volumetric modulated arc therapy, which is a new type of radiotherapy treatment planning and delivery technology, you can see that now when we look at these, you can see that the target volume with our high dose area is much more conformal. And again, when you look at our sagittal and our coronal images, you can see that the dose conforms nicely to the target volume, and that high dose area is no longer into the normal brain. So once we analysed the results of this study, we successfully implemented volumetric modulated arc therapy for our patients in our centre, which in turn we hope has improved patient outcomes and of course reduced the toxicity profile for our patients having radiotherapy. Another project that I led on was a hippocampal sparing radiotherapy project. The hippocampus is a complex structure. It's embedded deep in the temporal lobe. And these images here, the first one shows you a coronal view of the hippocampus, and you can see that's outlined in red. And we actually have two hippocampi, one on the left and one on the right. And the hippocampus is responsible for short-term memory, concentration, and our ability to learn. And when patients have temporal lesions, the hippocampus can be included in the target volume. And we know that radiation-induced damage to the hippocampus can play a considerable role in neurocognitive decline of our patients. So for this project, I wanted to explore newer techniques in radiotherapy and see if we could reduce the dose down for our hippocampal patients. So again, here are some images from the project that I led on, and you can see the image on the left. Again, I'll highlight out the target volume, this area in red, and you can see how the dose goes from red to yellow to green, and that signifies the dose fall off. So the area in red is the 100% of our dose, and then the area in blue is anywhere between 10 and 20% of the total dose. And you can see when we outline the hippocampus, but we don't employ any hippocampal sparing techniques, you can see the mean dose for both these hippocampuses was 15.1 gray. But when we implement a volumetric sparing technique, you can see that we can shield the dose nicely off both the brainstem and the hippocampus actually, and we could substantially reduce the dose down to the hippocampus using this modern technique for radiotherapy planning. This is another patient that was included in our study, and this time we have a left temporal oligodendroglioma. And again, you can see that when we don't employ any sparing technology, the mean dose to the left-sided hippocampus, is almost 24 gray. But when we employ our sparing technique, we can bring that dose right down to 7.7 gray, which is again a considerable saving. So again, we did this study, we published our results in Estro and wrote it up for publication. And again, we successfully implemented this technology for our patients. So currently all grade 2, grade 3, and now in the next few weeks, grade 4 patients in our department will be having hippocampal sparing technology for their radiotherapy plans. So again, just another example about how therapeutic radiographers can lead research projects which go on to trying to streamline and improve our radiotherapy planning techniques for our patients, in turn, hopefully improving patient outcomes and reducing our side effect profile. So finally, to move on to the last domain of practice, and that's research. And I am a National Research Scotland Fellowship. I have a fellowship which I wanted to look at, particularly elderly glioma patients. And I'll draw your attention to the images within this box. So this is actually images from a paper that was published back in 2020 by Dr. Verhoef and his team in Utrecht, but it really highlights what we want to do within our study for my fellowship. So here we go. Here's an elderly patient, and the area in red is a target volume. And you can see the high dose area within that target volume. But when we look at the lower doses of radiation, you can see that the normal brain probably receives anywhere again between 10 and 20% of the total dose. And within this study, they looked at the baseline MRI scan, so the pre-radiotherapy imaging, and they looked at the changes in the white matter tracts for these patients. So they did a baseline MRI scan and then a follow-up MRI scan 8 months after the radiotherapy. And you can see the areas in white here. You can see that there's been a reduction in the white matter tracts. So there's been demyelination of the white matter tracts in all these different areas in the brain. And these areas are distant to the target volume. So the radiotherapy in some way, even though we're targeting our target volume so precisely with our radiotherapy, any low dose to the normal brain is having these demyelination effects on our white matter tracts. So what I want to do is I want to have a look at radiotherapy dose and volume, and I want to look at MRI imaging features, and hopefully that will help us to predict the severity of neurological toxicity in elderly GBM patients in my department. So how are we going to do that then? So I'm going to use a study that we are currently running in Glasgow, which Professor Anthony Chalmers is the chief investigator at. And this paradigm study looks at evaluating a drug called olaparib plus radiotherapy and temozolomide in newly diagnosed glioblastomas. Now, olaparib is what we call a PARP inhibitor, and PARP is a protein, an enzyme which helps damaged cells to repair. And Professor Anthony Chalmers in his preclinical lab has published data to suggest that if we inhibit PARP, then we'll have an anti-inflammatory and a neuroprotective result in our brain tissue. So our study aim for my fellowship project is to quantify the changes of brain tissue based on the MRI scans for these paradigm patients before and after radiotherapy. We're then going to quantify the neuroprotective effect of olaparib in terms of the volume changes in the brain structure. And then we aim to correlate this data with the quality of life patient data in the hope that we will see that olaparib adds a benefit and will reduce the changes in the white matter tracts and reduce the volume reduction in sensitive structures in the brain, so that we hope to again improve patient outcomes and reduce the side effect profile of our radiotherapy. So in summary from my presentation today, I hope that I've shown you that therapeutic radiographers are central to the delivery of radiotherapy. We know that we can lead neuro-oncology patient services, and we're key to the implementation of advanced radiotherapy techniques. And hopefully by doing that, we can enhance our patient experience and hopefully our patient outcomes. Thank you so much for listening. Any questions, please contact me via Twitter or my email. Thank you so much.